So lung cancer has long been the leading cause of cancer death, and chest X-ray was one of the first imaging modalities used for lung cancer screening. Before 1980s, multiple randomized trials, often combining chest X-ray and sputum cytology, were conducted. At that time, organizations like the American Cancer Society even recommend annual screening, chest X-ray screening for smokers. However, none of these early trials showed a significant benefit or reduction in lung cancer mortality with chest X-ray, and therefore, a lot of these guidelines withdraw their support for chest X-ray screening by the 1980s. So the objectives of this talk is to review the evidence of chest X-ray screening. I'll highlight some of the methodological issues and reconsider some of the potential benefits of chest X-ray screening. So first, here are the 4 key randomized controlled trials that looked at chest X-ray screening for lung cancer. They're the Memorial Sloan Kettering Lung Project, the Johns Hopkins Lung Project, Mayo Lung Project, and the CHECK study. The first 2 studies actually assessed the additive value of sputum cytology. So I'll mostly focusing on the latter 2, the Mayo Lung Project and the CHECK study, because they evaluate the effect of regular chest X-ray screening. And among the 4, the Mayo Lung Project was the most influential and widely cited randomized trial that's really strongly shaped the American Cancer Society's decision to withdraw the support for chest X-ray screening. The Mayo Lung Project enrolled all men. All these studies actually only enrolled men, and particularly for the Mayo Lung Project, they enroll men between 45 to 80 years old, at least 1 pack per day, and they screen everybody in baseline. All the participants had a baseline chest X-ray screening with sputum cytology test, and they randomized those who did not have the lung cancer at baseline and into the study group, which had chest X-ray with sputum cytology test every 4 months for 6 years. And the control group, they recommend all the participants in the control group to have annual chest X-ray, but without ensuring compliance. So they followed up all these participants for 6 years initially, and then they later on extend the follow-up to 1996. So as mentioned, all these randomized control trials show no significant reduction in lung cancer mortality, but both the Mayo Lung Project and the CHECK study shows improved in stage at diagnosis. They find more early stage lung cancer. All the cancers that they found are more resectable, and therefore the survival is also higher. The incidence of lung cancer was higher in the study arm compared to the control arm. However, they found no reduction in lung cancer mortality. And so a lot of people raised concerns about biases, and particularly their concern was overdiagnosis in this group. So a lot of studies look at explore whether overdiagnosis exists in these trials. And Dr. Calvis published this paper earlier looking at the overdiagnosis in both the Mayo Lung Project and Memorial Sloan Kettering. We look at the tumor doubling time, calculating the tumor doubling time of these 2 study participants in these 2 studies. And if the volume doubling time was greater than 400 days, we will call that as a proxy for that overdiagnosis. So what he found was the median doubling time for the Mayo Lung Project was 101 days, and for the Memorial Sloan Kettering was 144 days. And only 5% of the cases across both studies had a doubling time of more than 400 days, and majority of the tumor was less than 300 days doubling time, indicating that they are very aggressive tumor. So the conclusion was that the data do not support the claim that there are frequent overdiagnosis in chest X-ray screening. So because all the previous randomized trials, the sample size was small, and there are critique about the different contamination and non-adherence and different problem and biases. So it was felt that benefits might have been missed in those trials, and therefore NCI decided to include chest X-ray in a much larger study. So they funded the PLCO study. It now and then include both men and women aged 55 to 74. There was no smoking eligibility criteria in the study, and they randomized participants to annual chest X-ray for 4 years versus usual care. And each arm has over 77,000 participants, and they follow up all these participants for 13 years. What they found was no significant difference in lung cancer mortality. And again, the incidence and stage distribution of cancers did not differ significantly. So the conclusion was that annual chest X-ray did not reduce lung cancer mortality compared to no screening, and it was interpreted as confirming that chest X-ray didn't work. But the absence of evidence is not the evidence of absence, as we know. And here are some of the methodological issues that we can see. There's issues with adherence and contamination. Some of the studies, it was not conducted in the high-risk population. The follow-up period was not long enough to observe the benefits. And some of these studies also, when they calculate the mortality reduction, they included post-screen diagnosis cancer. And each of these issues likely to dilute the potential benefits of chest X-ray screening. So when we look at the PLCO study, we know that the screening adherence was 86% at baseline, and as year goes by, the adherence dropped. And as for the contamination, we know that for the Mayo Lung study, Lung Project had as high as 50% of the participants in the control arm actually received chest X-ray screening. And in the PLCO, an estimated 11% of the control group actually received chest X-ray. So PLCO, as I mentioned earlier, they include participants with no smoking history, and about 45% of their participants were non-smokers. Therefore, it's a little harder to show the benefits of chest X-ray screening. And it is known that in I-ELCAP, we have shown that the true benefits of screening can be reached after 10 years. So if the study didn't design to have a sufficiently long follow-up, result will bias towards no masking the full benefits of screening. And these primary analysis always included lung cancer cases diagnosed after screening period has ended. So especially for PLCO, the follow-up period is very long. It was reported that only 20% of the lung cancer cases in the chest X-ray arm were detected during the screening round. And actually in this abstract, they also presented some of the results. They said it was shown that if we look at the results after 13 years follow-up, the 5 years survival was 24% in the experimental group versus 19% in the control group. There was only a difference of 5%. But if we limit it to only within 4 years, there's the difference between the two groups almost double. So it was shown that the benefits is diminished when lung cancer diagnosis was well beyond the screening interval. So with those issues in mind, we all know that lung cancer is highly fatal when symptoms have already appeared. Resected early stage lung cancer has a very high lung cancer survival. And we know that from I-ELCAP earlier, we have shown that untreated early stage lung cancer, all of our patients with untreated lung cancer die within 5 years. So detecting lung tumor while it's small is always better than finding when they're large. Smaller size is earlier stage, and they're higher likelihood of cure. And we know that in the previous study, they show that chest X-ray can detect more earlier stage lung cancer. So we believe that chest X-ray has the potential to improve survival. And Japan is good. I want to mention that Japan has been using chest X-ray as an annual screening for lung cancer. So some of the benefits of chest X-ray screening, we can actually see it in this long-term follow-up result paper from the NLST. They show that for all the stage 1 lung cancers, the 10-year lung cancer specific survival for the CT arm was 73%, chest X-ray arm was 65%. And from the SEER database, it was 56%. So the 10-year lung cancer specific survival in the low-dose CT arm was greater than the chest X-ray arm, and both of them were greater than the SEER database cohort. So we all know that CT is better than chest X-ray as shown in the NLST data. So as a conclusion, as CT is better than chest X-ray and better than usual care. So we're currently working on a new approach that would enable us to evaluate the benefits of chest X-ray screening while accounting for all the issues that I've raised earlier. While less sensitive than CT, we believe that chest X-ray is better than no screening in the high-risk population. And with Dr. Pesachorn has shown us earlier that with AI, we believe that the improvement of chest X-ray will further improve. And chest X-ray is affordable, is widely accessible, and already in a lot of the public health programs, such as the TB clinics. So we can leverage that infrastructure for lung cancer screening when low-dose CT is not feasible. So key takeaways: skepticism towards chest X-ray screening and from early randomized trial with design and analytic limitation may have obscured the potential benefits of chest X-ray screening. Absence of evidence is not evidence of absence. And we're now working on a new approach that will allow us to directly assess the chest X-ray screening benefits. And CT screening remains the gold standard for lung cancer screening, but in limited resource country, chest X-ray might be a useful tool, particularly with the use of AI. And at the end, more research is needed. We'll have to validate the use of chest X-ray with AI and also work on how to integrate CT with chest X-ray. Thank you.